So good afternoon, everyone. My name is Sakpal Tan. I'm the National Program Director for the National Pancreas Foundation. Thank you for joining today's webinar on pancreatic cancer, risk testing, and nutrition management. In this webinar, our speakers will talk about the most common risk factors, early detection and awareness, the importance of nutrition and movement, and we will then hear from our pancreatic cancer patient advocate. But first, I wanted to talk to you more about the National Pancreas Foundation. We fulfill our mission by awarding research grants. We endorse 189 NPF Centers of Excellence for pancreatitis and pancreatic cancer. And we have over 30 programs for patients and physicians. If you need help finding a specialist in your area, please email info@pancreasfoundation.org. We also have chapters nationwide. Chapters are a great way for patients and families to connect with each other and local NPF centers. Our annual fundraiser is Pancreas Bowl, which is happening right now. If you want to be part of a chapter, please contact Cheyenne, our volunteer and development coordinator. I also wanted to talk about Camp Hope. Living with pancreatitis is very isolating, and in partnership with Rebecca's Wish, we created Camp Hope. It is free for campers and volunteers. It offers connection, friendships, and a true camp experience with an on-site medical team. This year, we had 201 participants from 35 states. Camp Hope does not exist without volunteers. We encourage patients living with pancreas disease to apply, and Alicia, our patient speaker, was one of our amazing volunteers this year. The application will be ready this week. We fulfill our mission by providing educational resources for patients and providers. One of our most popular resources is our Animate Pancreas Patient. It's received millions of hits in the past 12 years. Check it out to learn more about pancreas cancer, surgery options, PERT, and nutrition. And then another resource that we have for those living with pancreas disease is our cookbooks as well. Between both cookbooks, there are over 80 recipes to choose from. I always tell patients every body is different, so make tweaks in their recipes when needed. And then follow us on our social media platforms. We post daily. And our next webinar is going to feature Dr. Melina Bellin and Dr. Darash Yadav, who is speaking on navigating exocrine and endocrine challenges post-acute pancreatitis. And today for our speakers, Dr. Andrew Coveler is our moderator and one of our speakers. He is an assistant professor at the University of Washington and the Fred Hutch Cancer Center. He's also the co-director of the Pancreas Cancer Specialty Clinic. Dr. Bryson Katona is an associate professor of Lynch syndrome research and associate professor of medicine and genetics at the University of Pennsylvania Perelman School of Medicine and the director of the Gastrointestinal Cancer Genetics Program. Shelby Yaceczko is an advanced practice clinical dietitian at UCLA in the Division of Digestive Diseases. And Alicia Avila is a life enthusiast and an advocate of smart change who is thriving beyond a stage 3 pancreatic cancer diagnosis. I also wanted to thank our sponsors, Revolution Medicines, Immunovia, and Nestle Health Sciences. We want to hear from you. We want to keep on doing these webinars. Please fill out our post-webinar survey. We want to tailor more webinars tailored to the feedback. And then if you fill out the survey, you'll be automatically entered into our raffle for an Amazon gift card. And then after this webinar, I'll also send an email with links to rewatch as well and the NPF resources that I just talked about. And now I will give the floor to Dr. Coveler, Dr. Katona.
Hello, thank you for the introduction and for having me and everyone here today. So during this webinar, we're going to talk about pancreas cancer, early detection, nutrition, and some coping. You probably have a box where you can type in your questions, which we'll come to at the end. And we have about 15 to 20 minutes per topic. So let's jump right in there with Dr. Katona and talk about understanding pancreatic cancer, early detection, risk factors, and testing. So let's just open it up with, what are some of the common risk factors for pancreas cancer?
No, thanks. Great first question. And I'd just like to thank the NPF for the opportunity to join today. This is such an important topic, and I'm certainly looking forward to hearing the other two speakers that follow me. So, in terms of risk factors for pancreatic cancer, there are multiple different ones that we can consider. One of the major risk factors can be related to genetic predisposition or family history of pancreatic cancer. But there are many other risk factors as well. So importantly, 90% of pancreatic cancers are thought to be sporadic and not related to any hereditary or genetic component. And so other risk factors for pancreatic cancer can include some lifestyle risk factors, such as smoking, such as obesity as well. But there are also non-lifestyle factor associated risks, such as increasing age, and there's a slightly increased risk with male sex. Although I will say that amongst females, the risk for pancreatic cancer has been increasing over the last several years.
I was going to say, what do you think has been driving that increase in risk? I understand pancreas cancer, it's been a little bit, but it says it's going to become the second leading cause of cancer death in this country.
Yeah, the statistics are, not very friendly to look at. We're seeing an increased risk in pancreatic cancer in both men and women. And interestingly, if you look at all the different cancers, we're seeing a reduction in many other cancers. So like colon cancer, lung cancer. But pancreas is one of the few cancers that's increasing in both men and women. I don't think we fully understand the risk. Certainly, there are the lifestyle risks that I mentioned earlier, but likely there could be some environmental risk as well that again I don't think we can quite put our finger on, but certainly could be contributing to this increased risk that we're seeing.
So when you look at those risks going up, what are the tests that are typically used to evaluate both your risk and then to detect pancreas cancer and detect the disease?
Yes, I think when, evaluating for whether or not you might be at increased risk for pancreatic cancer, I think that's an important area where genetic testing comes into play. So we can get into this later if wanted about who are the right people to pursue genetic testing. But nowadays, for individuals who may be at increased risk for pancreatic cancer, there are large panels of multiple different genes that increase pancreatic cancer risk that an individual can be tested for. And compared to 20 years ago, where oftentimes we were just testing for one or two genes at a time, now the technology is quite amazing, such that all of these genes can be tested simultaneously, with results coming back within a couple weeks, with actually a very reasonable cost, typically max out-of-pocket cost of $250. The genetic testing field has just remarkably revolutionized over the last 5 to 10 years. So that's typically, when we're thinking about individuals at increased risk, that's the kind of the first test. Do you want to, Dr. Coveler, I don't know if you want to go into like who should be tested first, or if you want to get into some of the ways that pancreatic cancer is actually diagnosed on testing as well.
Why don't we look into how would you test someone to see if they have pancreas cancer?
So typically, pancreatic cancer is detected on a scan, some sort of scan. There are multiple different ways that we can take pictures of the pancreas, which, as most of you know, kind of sits in the upper part of the abdomen, right behind the stomach. We can do CAT scans, we can do MRIs, or we can do something called an endoscopic ultrasound, where a thin camera is put down into the belly, and then ultrasound on the end of that camera is able to take a picture of the pancreas. Typically, I'd say the majority of pancreatic cancers that are detected or get detected on an imaging study after somebody is presenting with some potentially concerning symptoms. And then this imaging study of the abdomen, then will essentially show the new pancreatic cancer that has developed. And regardless of what imaging study is used initially, typically that's then followed by something called an endoscopic ultrasound, which again is a camera that's put down the mouth into the stomach, which can allow for a biopsy of anything abnormal that is detected.
You mentioned there a little bit about symptoms that people develop that might get them an imaging study. What kind of symptoms should people or patients be looking out for?
Yeah, it's a great question. I think there's really a range of different symptoms that can prompt concern for pancreatic cancer. Some of these symptoms can be very nonspecific. So, for example, unintentional weight loss, or basically you're losing weight when you're not trying to lose weight. But other times you can have pain in the upper part of the belly. You can have nausea or vomiting, or reduced appetite. You can also see some physical signs as well, such as a yellowing of the skin and the yellowing of the whites of the eyes. This is something called jaundice. Or potentially you could see some changes in the color of the stool as well. But oftentimes, any of these symptoms, potentially could, prompt your provider, one of your providers, healthcare providers, to order an imaging study.
And then what are your thoughts? You meet patients every once in a while, I'm sure, who are like, I saw my primary care doc and I had my blood tests were all good. How do I have cancer today? Any thoughts on blood test screening for cancer at this time?
Yeah, so I think when we think about screening for pancreatic cancer, that's a large topic in and of itself. Maybe I'll take one step back and just think, well, who should we actually be screening for pancreatic cancer? So pancreatic cancer is not like colon cancer or breast cancer, where really it's recommended that everybody undergo screening. Typically, pancreatic cancer screening should only be performed in the setting of a known genetic predisposition for pancreatic cancer, or a very strong family history of pancreatic cancer, typically with two close relatives in the family that have pancreatic cancer. And when we think about screening for pancreatic cancer, basically what we're looking for is we're trying to identify a pancreatic cancer at a very early stage, ideally a stage 1, which would then allow the pancreatic cancer to be resected and hopefully cured. And so when we're screening patients for pancreatic cancer, basically we're doing this in patients who do not have any symptoms at all. Because we're trying to find this cancer very early so that it can then be surgically resected. Now, in terms of how we do screening, there's two components to this. There's an imaging component, and then there's the consideration for use of blood-based testing for pancreatic cancer early detection. For the imaging component, typically individuals who qualify for pancreatic cancer screening would get an imaging study of their pancreas, typically every year. This is either an MRI of the abdomen or an endoscopic ultrasound. We think those two tests are much better than CAT scan, and so I do not recommend CAT scan. In rare circumstances, we use a CAT scan or a CT scan, but in general, screening should be done by either MRI or endoscopic ultrasound if possible. Now, there's been growing use of blood tests for pancreatic cancer early detection as well. One of the difficulties with blood tests is that, for example, for imaging, us as physicians have very clear guidelines about, how often imaging should be done and what type of imaging we should use. But for blood tests, there aren't actually any guidelines out there for physicians. And so I think physicians will oftentimes use varying practices in how they employ blood tests for pancreatic cancer early detection. The tests that are used and used out in the field can include testing for diabetes, as new onset diabetes can be a risk factor for developing pancreatic cancer. There's a blood marker called CA19-9, which is typically a marker that's elevated when somebody has pancreatic cancer and is then followed as they are treated. Some people use this kind of in the early detection setting. And then finally, there are two commercially available pancreatic cancer early detection tests that are out there now. One of these tests is called PancreaSure, and the other one is called Avantec. And these commercially available pancreatic cancer blood tests basically have been designed to try to pick up a very early stage pancreatic cancer. And so those could be considered as well, although with all of these blood tests, we don't have enough kind of data from high-risk patients undergoing screening to show that that they're very effective. Although that data certainly will come over time as they're utilized more frequently. Sorry, long-winded answer, but that's a big question.
So if someone, it was a great answer. It is a complicated topic. Um, how would you say you talked about the screening, whether it be MRI or endoscopic ultrasound, or maybe it's the blood test? How can a patient prepare physically and emotionally for that testing process?
Yeah, so I think before any patient undergoes screening for pancreatic cancer, I think it's important to have a thorough discussion with your healthcare provider just to make sure that the test is right for you. Your healthcare providers, will certainly be able to walk you through the test. I think in terms of blood tests or in terms of MRIs, I think most people have had those in the past, and so they'll pretty much know what to expect. I think a lot of people don't know what to expect with an endoscopic ultrasound, just because that's a much rarer test. And for those who haven't had or had exposure to an endoscopic ultrasound, what this involves is basically coming into the endoscopy unit, and prior to the procedure, an IV is placed. Fortunately, you don't have to do any prep for the endoscopic ultrasound. There's just nothing to eat after midnight. Once the IV is placed, the procedure takes about 20 minutes or so, and it's fairly quick acting anesthesia, and you're usually heading home, an hour later. But I think, just having a discussion about these tests with your providers is important. I think, probably the thing that people worry the most about is then waiting for the results after the test comes back. And, that can oftentimes be kind of, nerve-wracking while you're waiting for these results to come back. So I think that, obviously having a discussion with your provider after they do come back is incredibly important. As I know, nowadays, a lot of these results are released directly, especially MRIs and things like that. They're released directly to the patients. Oftentimes, at odd hours or in the middle of the night where their physician isn't available. And so that can sometimes be alarming to look at one of those reports for the first time without, having your ordering physician there to walk you through it.
And then in the last couple of minutes, let's say you have this one of these tests done and they find cancer. What would you tell someone the next steps are if that's what they find out?
Yes, I think once the diagnosis of pancreatic cancer is made, I think really and speed is of the essence, and it's really important to get in with an oncologist, potentially a surgical oncologist, hopefully if it's at a resectable stage. But I think that, once the diagnosis is confirmed, I think, not wasting any time and getting into treatment as soon as possible is key. And that, there may be some other testing involved. There may be testing on the tumor that's performed. There may be other types of scans that are performed, but I think just really trying to expedite all of that care to start the treatment process as soon as possible.
Great. Thank you very much for those insightful points. Thank you, Dr. Katona. We're going to move on to Shelby Yaceczko, who has a Doctor of Clinical Nutrition. She's going to speak with me now about pancreatic cancer and nutrition. So let's just open it up with, can you briefly describe what a good diet would be to decrease the risk of getting cancer?
Yeah, I think that's a good place to get started. So you've probably seen online the term coined Mediterranean diet. But we've changed that term recently to something called plant forward diet, which I think makes a little bit more sense for people and they're able to kind of apply it in their day to day and at home, depending on your food preferences or your culture or whatever types of foods that you enjoy and find palatable. So, this whole kind of umbrella term of a plant forward diet means that we've got flexibility built into the diet. We're adding things like fruits, veggies, nuts, seeds, minimally processed foods that are free of a lot of laundry lists of ingredients. We're trying to get animal protein sources as well as lean animal protein sources combined with plant protein sources. So you can think of things like your beans or your legumes or your lentils. So I think of it in the sense of trying to aim for plates that have roughly 50% coming from a plant is just a way to think about this. So plant forward diet, roughly 50% of the foods you consume coming from some sort of plant. And that we know in the research and just in like longevity and metabolic studies have shown to be some of the most protective patterns for chronic disease prevention and management.
Um,
Get
moving a little forward with someone who actually has pancreas cancer, can you describe what some of the typical challenges are for pancreatic cancer patients when it comes to nutrition?
Yeah, and I think a lot of things fall under this umbrella of what's called like nutrition impact symptoms. It's called NIS, it's abbreviated, sometimes you'll see. But people can kind of, on their individual journeys, struggle with things like loss of appetite, not feeling super hungry, losing weight or losing muscle without trying, having taste changes, smell changes, food aversions, feeling nauseous, or having altered bowel movements from diarrhea to constipation, or even just difficulties digesting foods we used to enjoy, like foods that are higher in fat or higher in fiber. So everyone I'd say has, generally speaking, there's kind of a dynamic process where things will pop up at different time points. So it's all about navigating that and finding ways to help mitigate and kind of manage those side effects when they come up. And then provide some quality of life around food so that way you don't feel like you can't eat anything at all or you're stuck on a liquid diet, because that's generally not the case, but it does involve a little bit of planning ahead to help manage some of these symptoms.
Do you want to, the holidays are coming up and people will be out and eating their meals with friends and family. What are some of the strategies to manage some of that difficulty with eating?
Yeah, so first things first, we always have to think we eat with our eyes and we eat with our physical selves. So sometimes we'll go to a celebration, we're super excited, we want to get like giant platefuls of food. So just trying to practice a little bit of mindfulness because overeating can lead to some of the side effects a lot of people will experience with holiday eating. So just reminding ourselves, what does our body need today and in the present? What's our movement been looking like? Are we able to walk around, help digest the food a little bit? So there's some of these strategies I think can be helpful at celebratory events or parties. And then when you're looking at your plate, you really can't go wrong, generally speaking, when you've got a little I call it a PCC, a protein, a color, and a carbohydrate. And that helps blend your plate out so you get a little bit of all the best types of nutrients, but you're not necessarily overeating in one category. So protein, color like a veggie, and carb like a good carb.
I like that. Practical ways to look at your plate of food.
Keep it
How
simple.
does how does the good nutrition help maintain weight and strength before, during, and after treatment?
Yeah, so we think nutrients, going back to like the fundamental of what nutrition is, it's fuel, right? So every time you eat, you're providing fuel for your body. So we can give nutrients in all different forms, right? We could eat a donut, we could eat a piece of fruit, we could eat a protein, we could eat a veggie. So when we're eating kind of a balanced, nutrient-dense diet that has a little bit of all the things our body needs to stay fueled, it's going to provide fuel for things like your muscle. It's going to provide fuel for things like your ability to move around and to stay energetic and keep those blood sugars controlled. It's going to help support things like your immune function and your gut health and be able to recover from treatment or recover from surgery or wherever you are in kind of your own individual health journey. So when you go back and dial in and say nutrition is fuel, and I have the choice, and kind of sometimes I can play around with my type of fuel. I can put premium in, I can put unleaded in, right? So think of it like gas in your tank. And the goal is that most of the time we're trying to put in that premium fuel to give your body the type of nutrients it needs to stay strong, and kind of perform at its best self. Very similar to an athlete, right? So a lot of patients I work with, we talk like you're an athlete. You're training for your chemotherapy, you're training for your radiation sessions, you're training for your surgery. When you think of that in that mindset, I think that helps motivate you and also understand the why behind what food can do for your body.
And when you speak about what food can do for your body, what are some of the key nutrients for patients with pancreatic cancer?
Yeah, so number one, we need enough energy. So when we're going through treatment, when we're going through surgery, the goal is not to lose a profound amount of weight or lose a ton of muscle, right? So we need enough energy to fuel our body, number one. So good calories. We need enough good protein to support our muscle health, the muscle regrowth, and things like the immune function in the body to recover. We need things like certain vitamins and minerals and good fats, healthy fats in the body to help lubricate everything, keep everything strong and going. So that's going back to that plate of if we're doing things like a protein color carb type of diet, we're getting in a variety of balanced nutrients that the body is able to kind of self-regulate to some degree and pick out what it needs and what it doesn't need in that day to fuel you. Your body's smarter than we think sometimes with nutrition. It's got a way to regulate itself and stay in like homeostasis.
Talking about all this nutrition, there's always a lot of discussion, at least I personally find it. Sugar. People talk about sugar and pancreas cancer. What would you have to say to patients about their sugar intake when they do or don't have cancer?
Yes. And I get this question, I feel like at least twice a day. So big concept, and this is how I like to describe it. Sugar in theory, right, feeds any cell in the body. Sugar feeds cancer. Sugar feeds non-cancer cells. But taking away sugar from a nutrition standpoint or when we stop eating all sugar carbohydrates does not make the cancer cells or the tumor die, shrink, or go away faster. So when we deprive our body of all carbohydrate sources, a lot of times what happens is we'll lose a lot of weight, muscle, energy. We don't feel good. It's a lot harder to get through treatment. And there's really not good clinical evidence to support that that's a good practice. So what I like to think is the relationship between sugar and cancer is not so straightforward and kind of linear, but we know that eating too much added sugar in the diet can promote inflammation in the body. And that can lead to things like chronic disease development or this kind of environment that's more conducive to the cells not being as healthy. So the goal is the types of carbohydrates or like the types of sugars that we're eating, we want them to come from whole foods that are more whole foods that are less processed. So things like your fruits, things like your legumes, your lentils, right? These are whole sources of carbohydrates that are going to provide a lot more nutrients than something like a cookie or something like a baked good that's really just coming from an added table sugar component. So there's a big difference in how the body uses those nutrients.
Meanwhile, someone's trying to track all of these things that they're supposed to eat and things like that. Have you found any helpful tools to support nutrition?
Yeah, I mean, I think it depends on the person. Sometimes meal tracking and like tracking everything you eat and really having this really defined plan can cause you to go feel bonkers and very stressed. So for some people, meal tracking is just not honestly a good idea because it can lead to more stress and more pressure and more anxiety. For some people, that helps you keep accountable. So I think there's all different ways that you can meal track. For some people, it's just my goal every day is to eat protein 3 times a day. I want to eat at least 2 veggies a day. And I want to make sure that I'm reducing my total added sugar or desserts per week to only twice a week, right? So now we're setting these like overarching meal parameters that feel a little bit simpler rather than tracking and logging every single thing we're eating. And it's like, oh my gosh, this feels like chaos. So I think figuring out what are your goals, what's your purpose of meal tracking, what are you trying to achieve, and how do you feel that it's going to be most successful with you without increasing your stress or increasing your fear and anxiety around eating, because that's no fun, right? Food is also pleasure and it's social, and we want to feel comfortable eating food and not shameful of that experience.
One topic I think we haven't hit on yet is as people are eating often with pancreatic cancer, sometimes they have some pancreatic enzyme insufficiency. So, how do we talk about or take a moment to talk about managing that, how you know if you have it, how to get those things to the right amount? So, as you said, your body does a whole lot for you, but when it's not working right, it takes a lot of work to manage that.
It sure does. So we have to go back to what the pancreas does at a fundamental level. So the pancreas does two main functions, secretes that hormone insulin that helps regulate our blood sugar, And then it secretes our digestive enzymes, protease, lipase, and amylase, which are those pancreatic enzymes that help you break down and absorb your carbs, proteins, and fats. So if we have endocrine or exocrine function that's not working as well as it used to, which is really, really common when we have cancer to the pancreas, we identify which or both that we have, and that will help drive our eating pattern. So in the example of if our blood sugars are going high and we have a new diabetes diagnosis, we may need to be falling with somebody that can help support diabetes management and the types of carbohydrates we're eating and how many carbohydrates we're eating with certain meals to help regulate those blood sugars. In the case of exocrine pancreatic insufficiency, where we're not secreting enough digestive enzymes, or if we've had surgery to our pancreas, where we have less total pancreas to do its job as well as it did before, then we may need to take a medication that gives us additional pancreatic enzymes with the meal times to help break things down. We also may need to adjust certain types of foods, especially foods that are high in saturated fat, or red and processed meats or heavy fried greasy foods can be a lot harder on your pancreas to break down when it's not secreting enough digestive enzymes. So figuring out how's the function of my pancreas going, and is there a diet strategy that can help provide relief, so that way I can have a better mealtime experience and improve my metabolic status, if you will, too.
Um, One of the questions I would have is you have these bowel issues from your pancreas potentially and your enzymes, and then for some people they're getting chemotherapy, which then overlaps. So I guess the question is, how do you work on managing the side effects during treatment and figuring those overlapping things from?
Yeah, I think it's important to go back to when are things happening. So for example, if we're having more like mealtime associated GI symptoms, we'll generally see that around times we're eating, right? We'll see that within an hour or two of eating. And we might have that urgency, bloating, gas that gets a lot worse when we eat, loose stools, stools that are kind of a lighter color, fatty, loose stool. And those may be more like every time I eat, this happens. So now that goes back and helps us collect data, say, okay, this is more tied to your eating versus is this something that's happening all the time? Or this is something that really just happens the 5 days around my treatment cycle. So I think creating sometimes a symptom log can be helpful for you. I had, chemotherapy on this day. These are my symptoms, but every time I'm eating, I'm experiencing this, or most times I'm eating, I'm experiencing this. That helps us figure out a little bit of where things may be kind of coming from, and then help you figure out what plan's going to be best with your medical care team and your dietitian. I also think sometimes there's not always an answer. So sometimes people will come and say, I ate this meal, it was amazing. I tried it 2 days later, it went horrible. And they're looking for an answer. And sometimes there's other factors. There's things like, were we really stressed out that day? Did we not sleep very well? Have we been having other life stressors that can also impact our things like abdominal pain or loose stools or diarrhea? Your mind is very, very powerful, and it can talk to your gut. So there are other things that can come into play that can disrupt kind of our gut function or our gastrointestinal health. And we have to think of ourselves in this like holistic manner that all systems work in play. And if one system's really stressed or overwhelmed or there's chaos, the feeling of chaos going on, that can disrupt things like your GI health and how your brain is talking to your gut. So sometimes just creating a space where it's okay to not know where things are coming from, but we can come up with some ideas to support you is a good way to navigate.
And as you talked about in that, you talked a bit about your brain gut connection. Can you spend a moment to tell us why mental health support's important when managing your eating habits with pancreatitis, diabetes, pancreas cancer?
Absolutely. So anytime an organ's not working as well as it could or should in the past or compared to our baseline, if we have inflammation to the pancreas, we have cancer to the pancreas, if we've had surgery to the pancreas, that can disrupt the body's physiological ability in the anatomy to do the things it used to do. And then if we feel nervous, we add on top things like mental health stress or feeling of chaos or feeling of anxiety with eating. That then is cross-talking over to our gut, can worsen those symptoms, or those symptoms can heighten for many people. And so having some sort of psychosocial support, mental health resources, someone to kind of check in with and work through some different strategies, whether it's diaphragmatic breathing or different forms of meditation, or some people use exercise or movement to help out. Those are all great ways to help reconnect the mind to the gut to hopefully reduce some of that crosstalk that's happening that we don't necessarily want.
You discussed movement. How does exercise, well, what would you say exercise and nutrition looks like for someone with pancreas cancer or chronic pancreatitis?
Yeah. So there's a new field if you haven't heard of it called like exercise oncology. And there's a lot of new research coming out in different types of cancers, cancer prevention, reoccurrence, et cetera, just highlighting the importance of muscle health and muscle quality. And we know that anti-cancer treatments, chemotherapy, immunotherapies, radiation, surgery, all of these things help, or all of these things reduce usually the amount of muscle we have and the quality of those muscles because it's really hard on the body, right? That's the reality of anti-cancer treatments. And so when we use nutrition and we use exercise, things like keeping our muscles strong together, we tend to tolerate our treatments better. We have improved quality of life, perhaps longevity. And we have, generally speaking, better clinical outcomes. So I think when we think of these things, I always like to say, like, use the tools in your toolkit. So you've got your mental health toolkit, you've got your exercise and physical activity toolkit, you've got your nutrition toolkit, you've got your sleep toolkit. Let's look at all these different ways that these can intersect in your clinical care plan and then break those down and see what opportunities you have because you may not realize how helpful some of these supportive care strategies can be on your journey.
Great. That sounds like all of the things that are probably reimbursed poorly, but are very important to patients' lives. So
Well,
thank you very much. Is there anything that you think I missed on asking questions for at the moment?
no, I would just say, the internet can be really a dicey space. So just be really mindful sometimes of the information that we're getting from different people online talking about pancreatic health or cancer prevention or in the cancer space. There's a lot of misinformation. I just saw a recent report showing like up to 80% of cancer related information from nutrition and physical activity and these things are have some form of misinformation in it. So just always, triple check what you're looking at, make sure it's from a credible source, a trusted source. And then always, work with your care team to see if there's evidence-based providers like your physical therapists, your dietitians, your social workers, to see if there's any opportunities in your care plan to enhance it. Because you won't know if it's there if you don't ask, and not everyone, unfortunately, tells you, as many of you know. So sometimes we have to be our own advocates to find the things that work for our needs.
Thank you so much for your time. We're going to move on to our penultimate section here, which is Alicia Avila. Her life was profoundly transformed after her stage 3 pancreatic cancer diagnosis in April 2021. This led to a 7-hour Whipple surgery, a tough recovery, and subsequent chemotherapy. Along the way, she embraced all 10 radical remission healing factors and discovered a deep joy in simple, meaningful moments. Today, she cherishes time with her horse Picasso, enjoys walks and conversations with her dog Takia Pepper, and finds her greatest happiness sharing life with her husband Pear. So thank you for being here with us today. We're just going to start with, can you walk us through your symptoms and when you were diagnosed?
Yes. Thank you. First of all, it's an honor and a privilege to be here. Very grateful to be able to speak about my experience after 4 years and a half. I started getting a little bit yellow and there was some pain on my upper abdomen. My family doctor started running test after test. And after repeating the blood tests 3 times, he said, I cannot figure out what's going on. Go to the emergency room. They need to figure it out. The only thing I can see is your liver and your pancreas are failing. And you need to go now. And I was like, first when he called, it's like, but it's not like I'm dying, right? He said, just go there so that they can figure it out. So finally, I convinced myself to go. When I was diagnosed in 2021, it was still the pandemic, it was still lockdown. So it's always kind of a pain in the neck to go through that process with all the steps that we needed to follow. So I went there, they ran test after test, ultrasound, they couldn't identify what was going on. Finally, by midnight, they run a CT scan and they find a mass in my pancreas. And from there was, they moved me from the hospital I was in to another one that had the team and the equipment to be able to do a biopsy and actually put a stent in the biliary ducts so that they could release anything that was blocking the biliary ducts. So it was an interesting journey.
Interesting. Interesting is probably a nice way to put it. What would you say were the unexpected challenges you had during your treatment?
The first one was the recovery. I decided as we assessed my scenario, we decided to go for Whipple surgery. And then the plan was to have adjuvant chemotherapy. Unfortunately, when they went in and performed Whipple surgery, they realized it was stage 3. It was already in the lymph nodes. So even though the tumor was very small, my doctors considered it was very aggressive because it was already in the lymph nodes at that point in time. So they decided to add radiation. So in my train of thought, it was like, okay, I go through Whipple surgery, but it shouldn't be that tough to recover. And I definitely underestimated that one. The recovery was very tough. Starting to eat again and knowing what to eat, it was just trial and error. It was like, okay, let me have some oatmeal with blueberries. Am I going to feel okay? Am I not going to feel okay? So it was a lot of trial and error until my digestive system finally, I was lucky enough for it to find its rhythm again. Then once I went into chemotherapy, because of the Whipple surgery recovery, I had lost lots of weight. So the chemotherapy with all the symptoms of not being hungry, feeling nauseous, not being able to eat, not being able to drink. They wanted me to go through 12 rounds. I could only finish 6. It was too much for my body. So they moved me to radiation, 6 weeks of radiation. And when we finished that, it was almost 6 months. And the question was, do you want to continue with chemotherapy or go into surveillance? There's no right or wrong answer. And at that point in time, I was very attuned to my body, and my body said, no more chemotherapy. And we went into surveillance, and 4 years and a half, of course, with ups and downs and all the challenges of aging. I'm very grateful to be here, be working full time, be able to walk my dog, ride the horse, still be able to even prepare my own meals, which I remember when I finished treatment, it was impossible.
Throughout this whole long journey, how did you keep your hope and your motivation during this challenging time?
Well, first of all, I remember when I got the diagnosis, and the first thing that happens is the emotional side of it. For me, it was the guilt and shame. Immediately hit me like a truck. Fortunately, at that point in time, I don't know how I was guided. We can call it, spirit, the universe, just the people that love me, that were surrounding me. I found this technique that was called cogno movement that could help me release those emotions, because there was a lot of guilt and shame, and especially when you have the C word, right? It scares the heck out of everyone, like the fear. When you're going through as I call it, through a cancer adventure, people around you gets triggered very easily, because it goes straight into the fear of dying, into the fear of getting cancer, into the fear of getting sick. And from there, helping me suppressed emotions, like to being released, that started giving me a different frame of reference. So I was able to make decisions from a more centered, and I call it like neutral place, where I could be an observer of what was happening and say, okay, we're going to move right, we're going to move left. Okay, I need to find a way to eat. I need to find different options. How am I going to be able to keep food down? How are we going to manage the side effects of the chemo, the dehydration, and being empowered to talk to my doctors, the doctors that I was very fortunate to have in my journey, and to have them all up to this day. They are always very open to discussing options, to say what are the perspectives, how do we manage risk. That was very important for me. And I think having that, finding the emotional support, finding the mental stability to find your center again, or to find your sanity, plus of course the physical changes that you have to do in your diet, and probably supplements, and probably find new ways of exercising, because through chemotherapy and radiation, it's not easy just to go for a marathon, right? So you have to pace yourself. You have to find where you are, that your body can still function, and give your body the best chance of success through the process.
And then I guess in my last question for this section, what would you give as advice to someone recently diagnosed? What was it that you wish you had known earlier that you would pass on to someone?
I wished I had found the book of Dr. Kelly Turner, the 10 Radical Remission Healing Factors. And as I was looking through my journey, I guess intuition, or just the love that people around me, like my husband, my parents, my brothers, my 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 cousin, they had for me, like it guided me. But if you look at that book, it contains all these factors, that it's mental, emotional, and physical. And it's like a guide on how to succeed on any difficult diagnosis or any health adventure that you may be facing. So I wish I had found this book before.
Fantastic. Thank you so much for taking the time and sharing your journey and perspectives. We've hit the Q&A section of the meeting. So I'm going to start with, because they were the earliest questions, that we can have all the panelists turn on their cameras. A little bit about chronic pancreatitis. We had several questions about the chronic pancreatitis, the risk of developing cancer from that. And in that, I'm going to tag on the question of what about pancreatic cysts and screening to make sure those don't become cancer.
Well, great questions. Really a fantastic session. I really enjoyed all the other interviews there. In terms of chronic pancreatitis, we do think that chronic pancreatitis is associated with an increase in pancreatic cancer risk. Although the risk is much higher for individuals who have chronic pancreatitis due to a hereditary cause. So hereditary that would be called hereditary pancreatitis. Those individuals have one of the highest pancreatic cancer risks. But in the absence of the hereditary component, there are different estimates out there, but for chronic pancreatitis, lifetime pancreatic cancer risk is sometimes quoted in like the 2 to 5% range. Now, the question about the cyst is a really important one. Cysts, for those who aren't familiar, are these small little fluid-filled pockets, basically like little bubbles that appear in the pancreas. Cysts are very, very common, and they increase with age. So if you look at 150 to 60-year-olds, about a third of those individuals are going to have a cyst. Now, cysts are very common, but and small cysts, fortunately, are not very worrisome. But once a cyst is found, then it's followed over time with imaging, typically first repeating in a year, and then depending on the size and the healthcare professionals' thoughts on this, subsequent repeat scans could be done every 1 to 2 years. But typically, if the cysts are less than a centimeter in size or less than 10 millimeters, we generally consider those fairly low risk. So hopefully that helps answer that question.
And then meanwhile, we're talking about cysts. Any comments on the difficulties of someone who's had a gastric bypass or frankly a pancreas surgery that might make that more difficult?
Yeah, that's a great question as well. I think when we think about digestive tract cancer surgery, sometimes that can make getting to the pancreas with an endoscopic ultrasound very, very difficult. So, one, we can't get there with the scope, so we can't take images and makes it very difficult to biopsy. Most of those individuals that have had a prior big digestive surgery, such as like a gastric bypass, usually we advocate for monitoring the pancreas primarily with MRI because MRI can be done and gets a good look at the pancreas regardless of if there's been a prior surgery that's been performed. I think the difficulty comes that if somebody's had, say, for example, a gastric bypass and then needs a biopsy of something in the pancreas, what are the options? And fortunately, we do have some workarounds. They can do a CT guided biopsy from the skin, basically from the outside of the belly. And actually, more recently, there's newer technologies that allow the endoscopist to basically reconnect basically the excluded part of the stomach to the gastric bypass and go and look at the pancreas that way.
Excellent. One of the questions here, which is probably both for Shelby and you, was about the higher rate because is there a higher rate potentially because of new weight loss drugs that are out? Does that contribute to pancreatitis or pancreas cancer? I don't know if we're just talking about the GLP drugs, but my guess. Any thoughts on how those affect your diet and cancer risk?
Do you want to go ahead, Shelby, first?
Sure, yeah, I was gonna say, you all can correct me if you've seen otherwise. I actually saw the opposite in a JAMA publication recently showing that the GLP-1 specific drugs may actually be protective. And that's thought behind some of the metabolic risk factors in the ability for some people to achieve weight management in ways they may not have done before, because we know that having too much tummy fat can lead to increased inflammation, which can be a risk factor for certain developments of cancer, including pancreatic cancer. I think like with any drug and any new drug class, we're going to have more and more research that can be compiled to better understand and see more of like the long-term effects. But I think right now, to my understanding, it's the opposite relationship.
Yeah, I agree. I'll just add two more points to that. Pancreatitis has been associated as a rare side effect from some of these GLP-1 medications, but it is a fairly rare side effect. And there was a lot of press about these drugs in pancreatic cancer when they first came out, but it's important to note that the pancreatic cancer that was being referred to is a pancreatic neuroendocrine tumor, where it may potentially these drugs may potentially slightly increase risk, but agree that for pancreatic ductal adenocarcinoma, which is the much more common classic type of pancreatic cancer, that all the data is overwhelmingly shown that these medications likely reduce that risk. Great question.
Alicia, I think there's a few questions here. First, I have more than one question wanting to confirm the exact title of the book and which book you recommended. And then also a question about caregivers, which I guess I'll give you a chance for the book first.
Thank you. It's the 10 Radical Remission Healing Factors by Dr. Kelly Turner. And regarding caregivers,
How can caregivers be the best help for cancer patients?
yes, and that's a tough one because as a patient that is navigating all the waves of cancer adventure, it's a roller coaster. And I would definitely recommend, and I take my hat off to my husband, that it was very important for him to put on his oxygen mask first, to manage all that was coming to him, so that when he was taking care of me, he was very supportive and he would be in a place where I could not affect him. Like, he was a firm believer that I could go through it. He was a firm believer that I was going to survive it, that I was going to be alive. On the other hand, there were many, many times that I thought I wouldn't make it. But every doctor, every meeting we had, and, as you are going through the Whipple surgery and the chemotherapy and the radiation, you meet, I don't know, I think I lost count at one point in time, many, many people. And you could see from the caregiver perspective, he was always certain it's going to be fine. What can we do here? What can we do there? And it's very important to have this open conversation that, we are not, no one is certain that we'll be here tomorrow. Just for us that have been diagnosed with a chronic illness like cancer, becomes more of a reality. And it's very important, even though you're in the middle of the storm, to find tiny little bits of happiness wherever you can. If it's just by enjoying a cup of tea, a big hug to your husband, your brothers, a friend, just enjoying that time. Because in the end, increasing those positive emotions is also going to help our immune system. So it's very important to take that moment. And as a caregiver, sometimes also it's difficult to see that in the end, the person that is experiencing that in their body will have the final decision. And that person may choose to keep doing the treatments, or that person may choose just, hey, let me live how much I'm going to live, fine here, and I will transcend, and that's fine as well. And I know it's tough as a caregiver, so it's very important to find that oxygen mask. Call it therapy, friends, find that support network is super important. And what I love about the book is that 70% of the factors, that means 7 of the 10 factors, are emotional and mental. And that's something that you can do, and then allow the doctors to do what they do the best, so that also you can help the treatments and with your positive thinking and with mental health, how to go through that difficult experience.
Thank you. Moving on to things that probably do help with getting through things would be exercise. I'm going to first go to Shelby with the question, since they tagged you. What is a good starting point to be active if you haven't been active before?
Yeah, I like to think of it as like mini nuggets of exercise. So it doesn't have to be a 30-minute full-on workout your first time, right? Can we find 5 minutes here, 5 minutes here, 5 minutes here that we're able to kind of add that up into 15 minutes a day? So I tell a lot of people I work with to make appointments for this, because it's very quick to go through your whole day or forget about it. So if we need to have a daily 9 a.m. appointment for walking, and then we need to have maybe 5 or 10 minutes of doing some light stretching or starting to move into some muscular based exercises later in the day, make appointments for yourself so that way you show up and you check in for your appointment and you complete those 10 minutes. You can make it even more fun and put $5 in a cookie jar every time you don't show up and then donate that or something. So you can, create your own kind of movement community with others, or create a space where you've got a buddy or somebody to help keep you accountable. But those minutes add up. And when we're moving and we're strengthening our muscles over time, you're likely to also feel less tired and have more energy throughout your day to do the things that you love doing, or bringing back some of those joys. So it doesn't have to be extensive. It can be 5 to 10 minutes a couple times a day. And then you can work and build that out, and work with things like a physical therapist or a cancer exercise trainer, or somebody that's unique to your own kind of healthcare needs at the time. But use it as a tool in your toolkit to fight and conquer some of the side effects that you experience, because if you don't try it, you don't know how it could benefit you.
Alicia, do you have any thoughts on getting that exercise back into your life?
Yes, I do. For some time, I was completely bedridden by chemotherapy, and they had to put me in immunotherapy as well. So it was like a double whammy. And I still remember Dr. Charles. He's a palliative care doctor. And he said, "You remember, your body is like a battery. So I need you to start moving so that you can start recharging that battery." And I literally started setting up. He said, "Set an alarm every hour. I need you to move. Start with 2 minutes. It can be just walking around the house, whatever you can do. Start with 2, then go for 3, go for 4. But I need you to start moving little by little." And then by magic, after forcing me to do that, you feel how you start regaining that energy. And I remember by the time I was walking 10 minutes, I was mesmerized. I was like, I managed to do 10 minutes today. So it's just tiny bits. Don't think that you have to go, all the way to the moon and back. Just little things, and you will start seeing the difference. I mean, the body is just this amazing technology.
Someone was curious to know what your typical day with food looks like, and that's for you, Alicia.
I usually, when I get up, I love to have my vegetable green juice. That's one of my favorite things. Cucumber, celery, spinach, ginger, and lemon. And then afterwards, I go for my protein shake. I found I had to test protein powders like for 2 years to find one that wasn't bloating me. It had to be a vegetable one. I started with the ones that were whey protein, and my system just couldn't bear it. So I went for one that it's sprouted vegetables, and that I've been taking for 4 years now, and my tummy likes it. And then afterwards, I also take my collagen with sometimes a little bit of matcha, or sometimes when I'm naughty, I go for a little bit of coffee because I still love coffee. And then once that's like my morning, it's all like liquid. My body feels good after that. And then I go for the lentils. I have an amazing mung bean soup that I found by Dr. Naram in the internet. If you Google it, you'll find it. And that mung bean soup, I've been taking it for 4 years now. And what I do, I just change the veggie that I add. So I have the lentil soup or the mung bean soup. And sometimes I will put bok choy or some sauerkraut, or I go for some sprouts, but then that changes the flavor. So I don't get tired of it. Because yeah, so far only my dog can eat the same thing every day and get excited. It's like, after a week, I'm like, what am I gonna do? So I change the veggie and then the flavor changes and I keep my mung bean. And then by night, what I do is, depending on the day, either I love vegetables now. I don't know how that changed, but just after Whipple surgery and chemo radiation, just my system was always craving something fresh. I either go for some like mushroom soup or salads. And there are some days where I crave meat or fish. So I try to go more for fish because that feels better in my stomach. And it took me like 3 years to really be able to take some meat. So now, like once a week, I try to get some grass-fed beef in my diet. But the more frequent ones are definitely salmon and fish in general. I realize that my stomach digests that way easier than the red meats.
Thank you so much for sharing all of those details about your life. Thank you also to our other speakers, Shelby Yaceczko and Bryson Katona, for being here today with us. I think in closing, I want to make sure everyone knows that your risk factors and to advocate for early detection. Understanding your own health and family history can help you have these conversations that hopefully you can have with your good medical provider. You should remember to prioritize nutrition and movement to support strength, digestion, and your overall well-being through treatment and recovery. Don't forget to lean on mental health strategies and support systems, especially during the holidays. You don't have to navigate the emotional and physical challenges alone. Stay informed, ask questions, engage with your healthcare providers. We are all here for you. There's also support groups where you can probably get insight from people like Alicia. I want to thank the National Pancreas Foundation for hosting this webinar. I want to thank our sponsors, Revolution Medicine, Immunovia, and Nestle Health Science. As a reminder, all the registrants will receive an email tomorrow so you can rewatch this. It'll also have NPF resources on pancreatic cancer. And I wish everyone a really good evening and holiday season.